Bismillahirrahmanirrahim. To continue our lecture about electrolyte disturbance, we are talking about hypercalcemia. Calcium level normally, serum calcium level, range between 8.5 to 10 milliequivalent per liter. Any derangement from this level, below that there is hypocalcemia. Above this level, above 10.5, hypercalcemia. Calcium ion present mainly in the bone as hydroxyapatite, and the other four, and this represents about 99%, while 1%, the other 1%, present or distributed in extra and intracellular space, or 0.99% in extracellular space and 0.01% intracellular. So very minimum fraction present in intracellular space. An increase in intracellular calcium will lead to destruction and death, programmed death, or what they call it, apoptosis of the cell. The extracellular calcium present in two forms, mainly the diffusible and non-diffusible one. The diffusible mean that one perform the cellular action, which represent the nerve action potential, muscle contraction, hormone secretion, and blood coagulation. These are the cellular function of the diffusible or biologically active calcium. The other form of diffusible, which is non-biologically active, is complex calcium, in which the calcium ion bind to oxalate. This molecule is not biologically active. So the only active one is the free ionized calcium. The other form is non-diffusible, which bind albumin and form a large molecule and cannot diffuse between intra and extracellular space, and cannot perform the cellular activities mentioned above. Now, concerning this extracellular calcium changes, how it increase or decrease the level of this calcium. The calcium level controlled by parathyroid gland by release of parathyroid hormone. If any decrement in the level of calcium level in the serum, there will be release of parathyroid hormone to act on, first of all, bone, and the release of calcium from the bone will replenish the level of calcium. On the kidney, will lead to the reabsorption of calcium from the loop of Hilli and collecting duct, as well as increase the level of active vitamin D biosynthesis in the kidney, which is 1,25 dihydroxycholecalciferol, that lead to the absorption of calcium from GI. So these are the action of parathyroid hormone on the target tissue. Now, in case of what are the causes of the increased calcium level in serum? Causes of hypercalcemia, mainly hyperparathyroidism and osteoclastic bone resorption, whether malignant tumor or hyperplasia, in which the parathyroid hormone will be increased and lead to the therefore this action to increase the calcium level. Second, excessive secretion of vitamin D or excessive intake through diet or supplement will lead to the increase the level of calcium. Second, certain drugs like thiazide will increase the level of calcium. Now, in case of hypercalcemia, what are the manifestations that be reflected on the patient with this hypercalcemia, with this disease? First of all, the action of calcium stabilize the sodium-potassium channel by guarding this and prevent spontaneous depolarization of this channel. So it will stabilize the sodium channel. So if it is increased, there will be decreased or absent reflexes on the neck. There will be a slow muscle contraction in a skeletal muscle, and there will be constipation due to effect on smooth muscle of the gut. On the CNS, there will be confusion, hallucination, and stupor. On the renal system, excretion of excessive calcium may combine with the other molecules like oxalate and form calcium oxalate stone. So it will lead to nephrolithiasis. Diagnosis of this disease entity by laboratory investigation: increased level above 10.5 milliequivalent per liter is laboratory diagnosis for this disease. ECG changes, special ECG changes, and laboratory investigation should be done to know the cause, like parathyroid hormone level, vitamin D level, magnesium, phosphorus, and albumin. Concerning the treatment, we have to increase the urinary excretion by usage of good hydration and enforce diuresis using a loop diuretic that decrease the calcium absorption. Second, increase GIT excretion of the calcium. Glucocorticoid decrease the calcium absorption through the GIT. Third, usage of bone resorption. Prevent bone resorption by using a biphosphonate or calcitonin to inhibit the osteoblastic activity.